Welcome, dear colleagues and all students, to our international faculty webinar for Young Indian Intensivists. Today's webinar number 168. So we have a very special guest today, special faculty, someone who has given the world the high flow nasal cannula. And he is Dr. TOMMASO MAURI from Italy. So it's a real privilege and honor to have you with us, sir. We are very thankful to you. So Dr. TOMMASO MAURI, he is Associate Professor of Anesthesia and Critical Care at Department of Pathophysiology and Transplants in the University of Milan, Italy. He is visiting associate professor and visiting scientist at Harvard Medical School. He is the person who has invented and he holds the patent for high flow nasal cannula. And it's really a very big achievement and really thank him for that. He's also the inventor of the apparatus for assisted ventilation and corresponding regulation method, and also the coordinator for PLUG, that is the Pleural Pressure Working Group, and collaborator for the International Scientific Working Group on Electrical Impedance Tomography Trend. And he has numerous publications, something like more than 150. And it is really an honor to hear from him on high flow nasal cannula. He himself has given the world high flow nasal cannula. So guys, you are in for a treat. Any questions we will take in the end. Over to you, sir. Thank you so much.
Thank you for the introduction. I don't like that much online, but I hope you will like my presentation. I prefer more interactive structure. I'm sharing my slides. So I will speak about high flow nasal cannula in hypoxemic patients, not in COPD and not in postoperative or post-extubation, because hypoxemic is my passion. I like to study ARDS, pneumonia, and especially when we arrive to ARDS, then the mortality is very high. So what we should focus our research, our treatment is really before intubation with high flow, and high flow plays a crucial role in this. These are my conflict of interest. So what is high flow nasal cannula? High flow nasal cannula is not a lot of oxygen. You can deliver 30 to 60 liters per minute, heated and humidified, even at a low FiO2. It's very common that we, in our ICU, use high flow with an FiO2 of 40%, 30%, because the main mechanism of high flow, the main physiologic mechanisms are not related to a lot of oxygen, but to the very high flow. It's very important that this flow should be humidified for the comfort of the patient. Dryness of the mucosal part of the airways is very uncomfortable, and also with the temperature, the mucociliary function should be maintained. So it's very important heating and humidification. But then the set FiO2 can be the desired level. Many times you start with a high FiO2, you decrease FiO2, you keep the same high flow. Is high flow a non-invasive respiratory support, or is just some, let's say, improvement of saturation? High flow decreases the work of breathing. This is esophageal pressure monitoring. You see, this is end expiration. The higher level is end expiration. During inspiration with no positive pressure support, you have a decrease of the intrathoracic pressure, so negative esophageal pressure swing, and then going up back to baseline. The area of this curve is called pressure time product, because this is time, this is pressure, and is a measure of work of breathing, metabolic work of breathing. Instead, the drop, the pure difference between expiratory and inspiratory esophageal pressure is the delta PES, esophageal pressure swing, which is a measure of the instantaneous effort. With high flow, you have a decrease of the esophageal pressure drop, of the esophageal pressure swing, and the decrease of the area subtended by the esophageal pressure over a minute. This is reduced work of breathing. So high flow does not only improve the saturation, is a real non-invasive respiratory support, because the respiratory support is a mechanism to decrease the patient work of breathing without or worsening gas exchange, or with better gas exchange. Because if you have decreased work of breathing, you are more likely to overcome the acute phase of pneumonia. If you have a very high work of breathing, this means very high transpulmonary pressure, because this pressure is transmitted to the lung, and very high load to the diaphragm. Patients who do not decrease their work of breathing during the pneumonia acute phase end up intubated, because they have lung injury and diaphragm injury. If you decrease the work of breathing, you protect the lung and the diaphragm and avoid intubation. This is the rationale for using high flow, because if you don't have positive pressure up here, above positive airway pressure, a decrease in the esophageal pressure swing directly translate into a decrease of transpulmonary pressure. Okay, so high flow is a lung and diaphragm protective non-invasive support. What are the underlying mechanisms that the very high flow uses or generates to obtain this decrease of effort? Well, for sure, improved oxygenation plays a role. However, improved oxygenation is a lot of cosmetics with high flow. It is a way to decrease the respiratory drive, so the input to the muscles, but only if the PO2 is very, very low. So if you put high flow and the PO2, arterial oxygen tension, passes from 50 to 100, well, that will be something that the respiratory drive feels and decreases the respiratory drive. But if you pass from 85 of arterial PO2 to 120, this will not be an input to the respiratory drive. Okay, so improved oxygenation by high flow is a way to decrease respiratory drive only if the starting value is very, very low, let's say below 60 millimeters of mercury. Why you have improved oxygenation? One method is very, again, cosmetic. You set the FiO2 on the machine and it's 60%. What the alveoli receive is much nearer to 60% than using a standard oxygen mask, non-occlusive. Why? Because if you have a non-occlusive oxygen mask, you have 60% FiO2, you have very high inspiratory flow, you will take some air from the room, which dilutes the FiO2. So the FiO2 decreases, okay? Instead, with the very high flow, 30, 40, 50, 60 liters per minute, the air that needs to be taken from the room is less. So you have better correspondence between the set FiO2 and the alveolar FiO2, okay? This is a very simple mechanism to improve oxygenation, but not very physiologic. The more physiologic is the PEEP effect. This is a patient on 30 liters per minute, 40 liters per minute, 50 liters per minute. And you see here the, let's say, mean airway, upper airway pressure passing from around 1 to 2 to 2 to 3, okay? There is variability during the respiratory cycle, but the average value is above the atmospheric threshold. So there is some end expiratory inflation with high flow. What is the mechanism for PEEP effect? Is the occlusion of the nares. So when you exhale with high flow, especially if you exhale only through the nose, mouth closed, you have these two prongs sending a very high flow inside the nose, and it will be more difficult or slower the exhalation. This generates a PEEP effect. And the larger is the prong compared to the nair, the more is the PEEP effect. Okay? So the PEEP effect should be correlated with the size of the prongs and with the flow, because it's the resistance to expiratory flow. Indeed, we performed this physiologic systematic review, and in this graph, you can see all the studies pulled together showing that with mouth open, the average PEEP effect between 30 and 60 is around 2 centimeters of water, mouth open. If the patient closes the mouth, then the PEEP effect goes between 4 and 6. Okay, let's say around 5. So a significant difference. So the PEEP effect by high flow is variable over time depending on the respiratory pattern and the mouth open versus mouth closed. The values are around here. There is a linear correlation between the PEEP effect and the flow. Flow above 60, we will speak about this a little later, are now available in many commercially available devices, but should be used with care, should be used carefully. The other side of the coin, the other main mechanism of high flow is reduction of dead space. What does it mean? That with the high flow compared to the standard mask, you can reduce the minute ventilation. Okay, tidal volume is 500 times 20, 10 liters ventilation. Then you apply high flow, tidal volume becomes 450, respiratory rate become 15, I don't know, and the minute ventilation drops by a third, 7 liters, 6 to 7 liters, okay? Usually, this leads to increased CO2. If you decrease respiratory drive, you decrease minute ventilation, you increase your CO2 in the arterial blood. Instead, with high flow, the PCO2 remains stable. So you can breathe less and have stable PCO2. Means that the system is more efficient in clearing CO2. Or maybe there is also some reduced VCO2, reduced production of CO2 by the reduced effort. Usually is a mix of these two mechanisms. Whatever the mechanism, you have a decrease in minute ventilation with high flow, so better CO2 clearance. The mechanism is washout of the upper airways. This is a study with nuclear imaging showing that after you start high flow, 45 liters per minute, very rapidly, you have a disappearance of the gases that is not, let's say, oxygen and air, fresh gases from the upper airways. If these were CO2, then you see the washout of CO2. CO2 is there because when you stop breathing, when you finish exhaling, the last air arriving at the upper airways has CO2 because it comes from the alveoli. So there will be CO2 here. If you wash out this, you have less rebreathing at the next breath, less dead space. This is not really correlated with the flow and up to 30 liters per minute or down to 30 liters per minute. What does it mean? That 30 liters per minute is the lower value, lower level of high flow rate, because there is a linear correlation with the CO2 washout up to 30. Okay? Then if you increase flow 40, 50, 60, you don't improve much CO2 washout, which is around 20% of CO2 production. Okay? And the drop in minimum ventilation is around 20%. So for the PEEP effect, the higher the flow, the more the PEEP effect. For the CO2 washout effect, if you go below 30, you lose some of these. But from 30 on, the effect is quite stable, okay? Unless you have very high respiratory rate, okay? With very high respiratory rate, increase in flow improves dead space clearance, okay? So it's very important to keep very high flows in hypoxemic patient with very high, very low PF ratio, so more hypoxemic will have more PEEP level, and with very high respiratory rate. So if you have a patient with PF around 80 and respiratory rate above 30, that's a very severe patient and we need 60, maybe 70, maybe 80 of flow. But if you have a patient who is hypoxemic and mild hypoxemia, PF 150, respiratory rate around 20, maybe a flow of 40 to 50 will be enough. So really, there is there are mechanisms by high flow who interact to decrease the neural respiratory drive, which is the output to the muscles to generate the effort. The effort generates lung stress and diaphragm stress too. This is the review that we wrote where we indicated the main determinants of respiratory drive. And you see there are 4 main chapters, domains, call it the way you want. Suprapontine input, the upper cortex dominating the breathing pattern, okay? So breathing is semi-automatic, but if you want to hold your breath, suprapontine control, you can. You just stop breathing for a while. Okay, the same in the opposite. If you want to breathe more, you can. So the suprapontine input increases the respiratory drive in hypoxemic patient due to anxiety, pain, discomfort. High flow improves the comfort, okay, and this leads to decreased respiratory drive. Then there is the PEEP effect. The PEEP effect is positive pressure at the end of expiration, and the let's say alveolar units will be less collapsed at end expiration. This means better mechanics and some recruitment. This means more negative feedback to the central respiratory drive. Why? Because inside the lungs, there are receptors which are mechanic, needs to be stimulated by stretch, okay? If you have lung collapse, these receptors will be hidden inside the edema and collapse, and the negative feedback will be abolished, and you have excessive respiratory drive. If you have some positive pressure, you reopen some alveoli, better inflation, and the stimuli to these mechanical receptors will be higher, increasing the negative feedback. Then you have better PCO2, better pH, better PO2. Okay, so better gas exchange will decrease the respiratory drive. And finally, there is the inflammation. Inflammation means cytokines coming from the lungs due to excessive lung stress. So maybe not in a few minutes, but over hours or days, the reduced work of breathing will reduce the stress to the lungs, and this will decrease the inflammatory chemokines reaching the central respiratory drive. Okay, so iFlow really has mechanism that covers all of the main determinants of respiratory drive. It decreases it, and this reduced directly the effort of the muscles, decreasing work of breathing and transpulmonary pressure, leading to better outcomes. Each of these effect is highly variable between patients and needs to be carefully monitored, okay? Not all patients have all the effects. Not all patients have the same extent of the effect for the same flow rate. As I said, the improved lung and diaphragm protection could lead to improved outcome. We wrote this review, which is guidelines for the use of iFlow. Now it is a little old, but shows that hypoxemic respiratory failure is the main recommendation for iFlow. Okay, it should be mandatory. Pneumonia patient, strong recommendation. Following extubation, moderate. Post-operative in high risk, obese, or thoracic surgery, conditional. And peri-intubation, before intubation, there was some discussion on preconditioning, pre-oxygenation, but there is no recommendation. However, the latest guidelines of RDS treatment published in Intensive Care Medicine a few months ago on iFlow recommends the use in pneumonia patient, but there is no evidence to improve outcome. Mortality. What does it mean? There is a signal in many studies, and also when you pull all the studies together, of decreased intubation. Okay, so if a patient is on iFlow and doesn't end up intubated, does very well. So if you have a ARDS patient, bilateral infiltrates, PF less than 300, non-intubated, within a week from the start of pneumonia, and you put on iFlow, if he manages not to end up intubated, he will do very good, okay? Very low mortality. The problem is that when you pull all patients together, so adding those who are intubated, the mortality is not different with other strategies. Why? Because iFlow is very powerful. And sometimes you don't recognize that your patient is worsening or is unstable, because iFlow can mask very well the respiratory failure. But if the inspiratory effort remains strong despite good oxygenation, with time, the lung injury will worsen and the patient will end up intubated. And those intubated on iFlow, especially after 48, 72 hours, have very bad outcome. Mortality more than 50%. So the advantage of less intubation is, let's say, lost by the very high mortality, excessively high mortality of those who ends up intubated, making the average mortality similar to not using iFlow. Clear? So there is a space for improvement. We are not done with iFlow research and with iFlow use. careful monitoring is for sure very important, okay? If you have a patient, especially in the ward outside of the ICU, you can use the ROX index, SpO2 divided by FiO2 divided by respiratory rate. ROX index above 4.88, let's say 5, is within 12 hours, is correlated with success. ROX index low, below 3.85, failure. The problem is that many patients, like let's see this patient, SpO2 94, normal, FiO2 70%. I would say very high, but it's not 100%, it's not 90. Someone could say normal. Respiratory rate above 30, but slightly above 32. So this patient to me is severe. But it could easily be in a ward, at least in my hospital. And if you calculate the ROX index, it's 4.19 in the gray area. So here we have a problem. Then even if you are very careful in monitoring your patient in your hospital, there are patients, and these are the most severe patients, in the gray zone, because having a ROX index below 3.85 is very difficult. The patient is very, very, very severe, and you will intubate right away. The problem is mostly the gray area. What shall we do with this patient? Because these patients are those who end up intubated after 48 hours of doing so and so on high flow and very high mortality. So there are means to increase lung and diaphragm protection by high flow without jumping to intubation. One is increasing the flow rate above 60 liters per minute. We performed the study with 0.5 liters per minute per kilogram of operated body weight, which means around 35. 1 liters per minute per kilogram of operated body weight, 65, and 1.5, which is around 100 liters per minute high flow. And we measured with electrical impedance tomography some benefits. This was published in Critical Care 2020. Rather than gas exchange, decreased heterogeneity, improved inflation, PEEP effect. Okay, so one method to maximize the physiologic effect of high flow in patients, let's say in the gray area, not really improving so much on high flow, is to increase the flow to 70 or 80 liters per minute. The problem will be that the comfort of the patient due to the noise, the very high flow in the air will be poorer, okay? And maybe the patient to tolerate this very high flow, so if a patient is 90, will be 1.5, but 90 is very difficult. Let's say 60, which is more realistic. 1.5 will be divided by 2 plus 60, so 90 liters per minute. You will have more PEEP effect, better inflation, reduced respiratory drive, but with some discomfort. And maybe the patient will need some sedation. We do use remifentanil or clonidine or ketamine. Another way to step up high flow treatment in patient not improving within 12 hours without jumping to intubation is awake prone positioning. This is a patient, the patient is reading the cell phone, they should be collaborating and tell them, lie down on your belly as you usually sleep at home. This study showed that if you perform lung ultrasound in the 12 spaces giving point from 0 to 3, and you prone the patient on awake prone position, and there is an improvement in dorsal aeration after switching back to supine, so you compare supine to supine, before and after from positioning. And if you have improved aeration in the dorsal part, comparing supine versus supine before and after, this is correlated with better outcome. Okay. So the first way to step up high flow in non-improving patient is higher flow than 60. And secondly, awake from position. Third method is something that came out more recently and is the asymmetrical flow rate. So this was the proof of concept of this. They generated asymmetrical high flow by using only one air. Okay. And they put 20 liters in one air and 40 liters in one air. This is asymmetrical flow rate because you have 40 here, 0 here. And you see the PCO2 dropped, especially with the asymmetrical at 40 liters per minute. Okay. And also the PEEP effect increased a bit. So there is a rationale since 2018 that if you have asymmetrical flow rates, you may maximize the PEEP effect and the PCO2 washout effect. So from this theory, from this, let's say, proof of concept study, came out the idea to build a new cannula. The new cannula has an asymmetrical design, right prong larger, left prong smaller. This, during expiration, generates an let's say, a favorable primary outflow for CO2 from the narix with the lower flow, while the upper flow continues washout. This generates more washout during the expiratory phase and not only during the, let's say, pause between two breaths. That is what happened with the standard high flow. Okay, so preferential way for washout of CO2 should mean improved efficiency compared to standard high flow in CO2 washout. Also, if you compare the same size of the, let's say, standard cannulas and comparing to the asymmetrical cannula, the occlusion of the nares is more for the asymmetrical. So if you have a measure medium and measure medium, the same measure, the asymmetrical will have larger occlusion. And this should be related to a better PEEP effect, pressure increased. So these bench studies, this is another one, show that high flow with the asymmetrical cannula generates PEEP compared to the standard cannula higher, you see, and also the dead space clearance is higher and less variable. Okay, so if you put the patient on high flow 40 liters per minute with the standard and the asymmetrical cannula, you should have an improvement of the effect of high flow. So this can be seen as a step up of standard high flow in patients who are not improving. Is this true in patient, real life patient? This is a small study that we performed in 10 hypoxemic patients. These were patients in the ICU on high flow for clinical indication. And we measured PF ratio, which was below 300 in all patients. So this means truly hypoxemic patient, because if they were without high flow, they would have been even lower, their PF ratio, and already was around 200, 240. So we compare the traditional cannula at, let's say, minimal high flow and maximal high flow, and the asymmetrical cannula at minimal and maximal. Okay, so high flow versus high flow, conventional cannula versus asymmetrical cannula. What we measure is a decrease in minute ventilation from the conventional to the asymmetric interface. So this is always high flow, this is conventional, this is asymmetric. The patient could breathe less. PCO2 didn't increase, even though they breathed less, and esophageal work of breathing decreased. Okay, so if you have a patient on high flow 40, not so much improving, if you pass to an asymmetric cannula, you will have a decrease in inspiratory effort, which should correlate with more protection for the lung and the diaphragm. This was true also when we maximize conventional high flow. So we put 60 liters per minute. So this is a patient on the maximum level of high flow. You shame the same level of high flow rate, but you put also an asymmetrical cannula, and you see that you have further decrease of minute ventilation and of inspiratory effort with no change in PCO2. So this means that asymmetrical high flow may have washout, enhanced washout benefit as compared to standard high flow, both at the intermediate low value of flow rate of 40 and at the very high value of 60 liters per minute. What about the PEEP effect? We measure PEEP effect indirectly. With electrical impedance tomography, we assess the end expiratory lung impedance. Okay, if you have more impedance at end expiration, means that you have better inflation, some PEEP effect. And this is the graph. From conventional high flow to asymmetrical high flow, end expiratory lung impedance increasing 1, 2, 3, 4, maybe some of these didn't change much. Instead, Chris, Greg, and their brother, and sorry, if you have end expiratory lung impedance measured with DIT, and you increase the PEEP effect, you should have increased lung volume. But you see that the effect was very mixed. Some patients decreased, okay? Also passing from at 60 liters per minute. So with the AT, we could not measure a consistent PEEP effect, while the reduced minute ventilation, improved CO2 washout, was much more consistent in all patients. So better CO2 washout, not so much PEEP effect. There is also another new study which came out from the Padova Center, and they didn't see much of the same results with the asymmetrical cannula. But they studied very different patient population, not, let's say, truly hypoxemic. This patient had PF ratio below 300 on Venturi mask. So our patient had less than 300 on high flow. But this patient had less than 300 on Venturi. So maybe with high flow, with the standard high flow, they would have been above 300. And right after, within 2 hours from extubation. So some hypoxemia on Venturi mass after extubation is very common. To me, this means a not very much selected patient population. If you put high flow, standard or asymmetrical in this patient, you don't see much different in minute ventilation and PEEP effect. This is effort, thickening fraction of the diaphragm with ultrasound, meaning that there is a difference from Venturi mask, okay, but not a step up improvement with asymmetrical, which is reasonable because these are not very severe patients, and the large improvement is already with the high flow. But still, in this study, you see that the comfort improved with the asymmetrical. And comfort is asking the patient how much comfortable you are from 0 to 10, and is a very, let's say, comprehensive measure of different mechanisms like hydration, heating, but also dyspnea. So also here there is a signal in improved, let's say, physiology with the asymmetrical cannula. So when you have a patient that you start on high flow because he's hypoxemic and maybe he's not so much improving, maybe he's in the gray area, an alarm should sound, because if the patient ends up intubated after 48 hours, mortality is too high, 50–60% mortality. We should do something. Intubate early, maybe, but also there are some step-up approach. Higher flow rates, awake propositioning, asymmetrical cannula. To conclude, this is a simple, very short review that we wrote in the intensive care medicine this year, and it shows a very simple step-by-step approach. We have some setting with high flow, and the setting is the flow rate, 30 to 60, but also 70, 80, the FiO2, the least to obtain decent saturation, the temperature, the highest tolerated by the patient, and the type of nasal prong, larger, smaller, everybody can have those. Asymmetric is a new one. Each of these settings collaborate to obtain a physiologic effect of high flow. Better PEEP effect, increased alveolar FiO2, more corresponding to the set FiO2, higher CO2 washout, better comfort, better humidification, okay? These are all crucial for the final outcome of the patient. Even comfort, even humidification. Why? Because one of the key elements of high flow is that you can keep it for 24 hours all day. Instead, for example, non-invasive ventilation with face mask or even with the helmet is not so comfortable. You can keep it for a few hours, 10 hours, 12-hour maximum, okay? So all of these collaborates to the physiological effects and to the clinical outcomes. Reduced intubation, and maybe if we monitor well our patient, reduce mortality. To monitor, EIT and esophageal pressure are very precise in measuring work of breathing, PEEP effect, but by now are a little advanced and left to research. So if the patient is in the ICU, we can monitor the effort, the respiratory pattern, and the gas exchange. Outside of the ICU, we have some indirect measure of dyspnea and comfort, and we have the ROX index, SpO2 divided by FiO2 divided by respiratory rate. It's very important not only to monitor, but to monitor over time. The patient which is severe and not improving is very severe, is a candidate for a determinant of worse outcome as compared to a patient who starts very severe but rapidly improves, okay? Monitor over time is crucial. So if you have a patient with pneumonia, start on high flow, set the highest tolerated rate, monitor. If the ROX index does not go above 5 within 12 hours, bring to the ICU, monitor, try step-up approach, proposition, asymmetrical, CPAP, but within 24 hours, 36 hours, decide. If the patient is not improving, remains severe, intubate. And I stop here. Thank you.
Thanks so much, sir. Very nice presentation and very clear. And starting from the basics and updating the latest with asymmetrical cannula. Thanks so much. So I request the audience to put up their questions. Meanwhile, Dr. Mauri, sir, I'll just put up some points for discussion, which would be of interest to everybody. So first of all, sir, there are many students and fellows here. They would like to know how to actually start the initial settings. When you put the high flow cannula, how do you put the settings?
Okay. I think the most important is to have an idea of why the patient needs high flow nasal cannula. So if the patient needs high flow nasal cannula because he's very hypoxemic, you will start with a very high flow rate. Okay. And the FiO2 is the last that you set. The temperature is a main determinant of comfort. So higher temperature maybe is more physiological for the humidification part, but it's also less comfortable. So maybe I will start with the intermediate temperature and increase over time. And the type of nasal prong is always a balance between the size of the nose of the patient. Many of our patients, for example, have nasogastric tube because they are surgical patients, so you will be obliged to use a smaller cannula. But again, I don't think that everything very high or very large is always needed. Like PEEP or tidal volume. If you increase PEEP, if you increase tidal volume, you obtain better oxygenation, but it's not physiological. So the idea for high flow is similar to mechanical ventilation. You choose the lowest setting to obtain stable improvement.
Right. Thank you very much. So moving on to the second point, sir, about maybe you can just stop the So moving on to the second point, sir, about carbon dioxide washout. Now, ideally the patient is supposed to be having his mouth closed to generate PEEP. So you have high flow coming in from the nares. So where does the carbon dioxide actually go out from? It goes out from the mouth or it goes out from the nares? How does it go out?
I agree that CO2 washout, when you have two same size prongs, is not so easy because there is this flow coming in and should find a way to go out. So maybe at that point, having the mouth open could improve the washout, but will also decrease the PEEP effect. So it's a balance between the two. So when you have a mouth closed, the washout is going in from the nares and going out from the nares. There is no other way to go out. But when you open the mouth, this improves. So the asymmetrical cannula is a way to maximize this washout without having the mouth open, because you can keep the mouth closed and you will have a preferential way for the CO2 to go out, the nair with the smaller cannula.
Thank you, sir. So moving on to the next point, what happens to the airway resistance? Is it because you humidify, you give warm air, so you cough out the secretion? So this is actually supposed to decrease the airway resistance, right? But there is a study.
Inspiratory resistance are decreased, yes.
So there is a study from Dr. Brocha's group. They say that they found that the resistance is increased, especially in expiration. And they say when you expire against increased resistance, the expiratory time is increased, so the RR decreases. And the RR decreases, so the minute ventilation decreases. So is that also a contributory factor? I mean, is this actually correct in your view? What are your comments?
Yes, those are, so first, it's not easy to measure resistance in non-intubated patients. So these are marker of airway resistance. The theory is that the inspiratory resistance should be improved, yes, decreased with high flow, because you have better secretion clearance, because you have some PEEP effect, stenting the airways, because you have the very high flow that supports your inspiration. While during expiration, especially with the mouth closed, this is against a continuous flow inside your nares, which opposes to expiration. And that is likely to generate some expiratory resistance. So if you have expiratory resistance, the flow rate of expiration is lower and the expiratory time takes longer, but also the mean airway pressure during expiration will increase because the drop in airway pressure will be slower, okay? This will increase the positive airway pressure at end expiration, but not only at end expiration, during whole the expiratory phase, leading to the PEEP effect and to better inflation. So usually we are taught, we usually think that expiratory resistance increasing is a bad thing. Instead, with high flow is a positive effect of increased PEEP at end expiration. This is true, especially if the respiratory rate is not so high, okay? So if it's around 20, 25, which is very common for hypoxemic patient on high flow. It may become a problem if the respiratory rate goes up to 35, 40, but you will not leave a patient on high flow with 35, 40 of respiratory rate. You will do a trial, put high flow. If the respiratory rate goes down, you are happy. If it remains at 35, 40, I think that the patient needs some step up.
Thanks, sir. Thanks for the detailed answer. So just a couple of points more, sir. In interstitial lung disease, lungs are very fragile, sir. Huh? There's some fibrosis and all. Do you think this would be very good for patients with interstitial lung disease?
Interstitial lung disease is a decrease, especially of compliance. And by definition, the decrease is not of compliance should not be, let's say, improved by PEEP, by recruitment. Okay, so for ARDS, you have a decrease in compliance with which is recruitable, a decrease in because of lung collapse. Instead, with interstitial disease, you have a decrease in compliance because the lung is stiff, is not small. So if you put high flow, you may have some inflation that can even worsen lung compliance. So I don't think the PEEP effect is something you want to obtain in this patient. These patients are better with very low PEEP. At the opposite, with the CO2 washout effect, may be relevant for interstitial patient because there is less need to breathe. You can decrease the respiratory rate and decrease the respiratory effort. This will relieve especially the respiratory muscles. So high flow may avoid muscular exhaustion in interstitial patient. I would use it. I'm not, I work in a general ICU, not only a pulmonary one, so we don't have much non-intubated interstitial patients. But if I were to use it, I would use it with a flow around 30 to 40 liters per minute, not going to the very high flow.
Thanks, sir. Thanks so much. Sir, final one more question. Now, sir, you know, the PEEP effect is important for high flow nasal cannula, but it depends on the mouth closing and mouth opening. And most patients are hypoxemic, hungry for air, so they breathe with their mouth open. So the PEEP effect is practically very less. Yet your high flow nasal cannula works wonderfully well. We have all seen that. Now, you know, this concept of, you know, treating ARDS with high flow nasal cannula without PEEP or with minimal PEEP is, you know, against the basic principle of mechanical ventilation, where we use high PEEPs. So do you think we can kind of put this principle into mechanical ventilation somewhere?
In mechanical ventilation, we don't use high PEEP. We use personalized PEEP. High PEEP is a very old concept. So some patient benefits from high PEEP, some patient benefits from low PEEP. So I don't agree that in mechanical ventilation we use high PEEP. I agree that with high flow, the PEEP effect is low. At 60 liters per minute, the maximum that can be achieved is around 5, and variable with mouth opening or mouth closing. One answer is accept this, you will know that your patient, you already know that your patient will have variable PEEP effect. Another is let's ask the patient to collaborate. We always do active physiotherapy in this patient, always from the very beginning. So what part of the physiotherapy can be to breathe with the mouth closed for a certain amount of time. You can ask the patient to do this. Keep the mouth closed for 5 minutes, 10 minutes, cyclically. So in this way, you will maximize the PEEP effect. But I agree that the PEEP effect should be kept in mind that is variable over time. I don't agree that this is always against what we need for ARDS, because sometimes low PEEP level in non-recruitable patient, especially in pneumonia patient, is the way to go even after intubation.
Thank you, sir. So I think, sir, with that, we shall conclude, sir. There are no questions from the audience. The wonderful interaction and wonderful presentation. And it was indeed an honor to have you with us, sir. You have given us
very happy that you for the invitation. Thank you very much. I hope
thank
this
you very
was
much, sir. Hope to hear more from you on high flow nasal cannula, sir. Thank you so much.
or also for on something else. We can discuss PEEP or ECMO if you want.
Yeah, I mean the world will hear something more from you on high flow nasal cannula, not just the lecture. The asymmetrical work you are doing, asymmetrical cannulas and so on and so forth, sir. Thank you so much.
Bye. Thank you very much.
Yeah.